welcome. Welcome to this session of the topic and focus on constitutional thrombocytopenia. I am Mariam, and I'm the education manager of the ERN-EuroBloodNet. It is my great pleasure to welcome you on behalf of the ERN to this fourth session. This series is an accredited European online educational program that targets health professionals, and that is organized by the ERN in partnership with the CRPP, the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, the French Constitutional Bleeding Disorders Network. So this program consists of a cycle of 15 webinars developed in collaboration with 3 experts: Professor Marie-Christine Alessi, Professor Saultier, who we have here tonight from Assistance Publique-Hôpitaux de Marseille, a member of the ERN, as well as Dr. Mathieu Fiore from the CHU Bordeaux, who is also with us tonight. Our goal with this program is to disseminate up-to-date knowledge among interested hematologists, internists, pediatricians, or other healthcare providers to give visibility to cutting-edge advances in the field of constitutional thrombocytopenia. So before we start, please note that the session is recorded and will be uploaded in the EuroBloodNet e-learning environment. If you do not wish to appear, just keep your camera turned off and change your name on the platform. Also, be kindly informed that your microphone is muted too. If you have any questions about the presentation, please use the Q&A button that is on the bottom of your screen, and they will be then answered after the presentation. So as mentioned, this program is accredited by Continuing Medical Education Points issued by the European Body of Accreditation in Hematology. You can request 1 credit per session or 15 credits if you follow the whole program. To request those credits, just make sure your name and surnames are visible on the platform, and then fill out the attendance survey that I'll link in the chat. And finally, answer the 3-question short satisfaction survey that you will receive after the webinar. So today is the 4th webinar of this series. Please join me in welcoming Professor Anna Savoia, who will lead this lecture entitled Constitutional Thrombocytopenia related to GPIb-IX-V complex defects. Professor Savoia is a professor in medical genetics in the Department of Engineering for Innovation Medicine at the University of Verona, Italy. Her main research area of interest is human and medical genetics in hematology, and concretely the identification of genes and mutation causing inherited hematological diseases such as thrombocytopenias and Fanconi anemia. Moreover, she's focused on the studies on pathogenic mechanisms responsible for these diseases. She's the author of 150 peer-reviewed publications. Professor Savoia, the floor is yours.
Okay, good evening to everybody. Thank you, Mariam, for your presentation. And as you mentioned, I'm going to talk about the thrombocytopenia associated with the defect of this receptor. So I cannot move to the next slides. I don't know why. Okay, so I do not have any conflict of interest to declare, and let me say briefly what I'm going to talk about. So I will mention briefly of some features of the receptor. Then I'm going through the Bernard-Soulier syndrome of both biallelic and monoallelic forms. Briefly discuss about the diagnostic approach and mention about another disease associated with the defect of this receptor, which is platelet type von Willebrand disease. So the GP1 and the GPIb-IX complex is expressed only on megakaryocytes and platelets, is the second most abundant sorry. is the second most abundant adhesion receptor on platelets, and it is involved in many functions, mainly primary hemostasis, where after vascular injury, platelets interact with components of the subendothelial matrix, such as von Willebrand factor, to seal, to repair the damage. And other functions are related to thrombopoiesis, platelets clearance, inflammations, and other. The three subunits of this complex, alpha, beta, and 9, in a ratio of 1 for alpha, 2 for beta, and 1 for 9, associated in the endoplasmic reticulum, mature in the Golgi apparatus, and translocated to the plasma membrane. The expression and the correct assembly of all these three subunits are necessary for the expression of the complex on cell surface. And on the platelets surface, the complex weakly interact with another glycoprotein, GP5, in a ratio of 2:1, as you can see in this picture. So what about the features of the subunit? Alpha, beta, 9, and 5 are leucine-rich repeated proteins of different size in terms of amino acid, as you can see here, or kilodaltons here. And with the GP alpha being the largest subunit, in contrast to beta and 9, which are much smaller. The proteins are characterized by actinial peptide, which is a short peptide of 16 or 26 amino acids at the end terminus of the protein, which is important to direct the protein to membranes. After removal of the signal peptide, the subunits consist of 3 domains: the extracellular glycosylated domain, the transmembrane domain, and the cytoplasmic tail, which is important for interaction with a component of the cytoskeleton, such as filamin A, protein 14-33 zeta, and others. Interaction among the subunits are very important for the stability of the complex. There are disulfide bonds between GP1b alpha and each subunit of the GP1b beta, as you can see here, the disulfide bonds, but also an important interaction, non-covalent interaction among the transmembrane domain of alpha, beta, and 9 proteins. As I said, there is also GP5, which is weakly associated with the complex with GP1b alpha through interaction in the transmembrane domain. As I said, the alpha subunit is the largest one, and it is exposed well above the platelet's membrane, and it is characterized at the end-terminus portion of the extracellular domain by the 8 leucine-rich repeats, which are the binding site for von Willebrand factor. Just close to this domain, there is another domain, negatively charged, important for the thrombin and the binding with the thrombin. I would like to remind you that ristocytin, which is an antibiotic, is important because in the diagnostic test setting, because it triggers the binding of von Willebrand factor to GP1B alpha subunit, inducing platelets agglutination, also known as RIPA test. What about the genes? Genes are very small, localized on chromosome 17, 22, and 3q. And as you can see here, there are very few exons, and except for the B gene, the coding region of A, 9, and 5 are all located in the same exon. Just to remind you that the opereading frame of GP1BA could be of different size because of the presence of 33 base pair, which could be repeated 1, 2, 3, or 4 times. A lot of mutations have been identified in GP1BA, GP1BB, and GP9 genes, and these mutations are associated with Bernard-Soulier syndromes. There are a few specific mutations associated with platelet type of von Willebrand disease. At least to my knowledge, there is not a mutation so far described for the GP5 gene. Bernard-Soulier is a very rare disease, 1 per 1 million live birth. So 10 years ago, we established an international consortium with the aim to define and characterize the features of the Bernard-Soulier syndrome. As you can see from these pictures, a lot of groups participate in the consortium from North, South America, from Australia, Japan, Europe, not only from Italy, but also from Ireland, France, Germany, Spain, and so on. So we were able to collect 161 patients from 121 unrelated families. And the features we collected are listed here. So this is, I remind you, the most severe form of Bernard-Soulier syndrome, which is an autosomal recessive disease. So patients have mutation at both alleles. So the mean age of diagnosis was 16 years, with a wide range from birth to 75 years. Thrombocytopenia is moderate or severe. The mean platelet count was 51 times 10 to 9th per liter, again with a very wide range. And there are platelets which are large, or even giant. The expression of the GP1B9 receptor was absent in 80% of patients and associated with a severe platelet function as determined by the absence of RIPA, so the absence of aggregation induced by ristocytin, which was absent or strongly reduced. The bleeding tendency was variable. As you can see here, the distribution of patients on the basis of bleeding score from 0 means non-bleeding to 4, which is the most severe bleeding. So 50% of the patients had severe bleeding, and the other 50% no or mild moderated bleeding. And the bleeding tendency was independent of platelet count. Just to remind you that 50% of patients in this cohort received the previous misdiagnosis of ETP, and they receive angiotherapies such as immunosuppressive treatments and even splenectomy. These are the spectrum of mutation we found in this cohort of patients. Here again, the subunit, alpha, the beta, and the 9. The different box with different patterns means a different region, different domain of the subunit. So the tail domain, the transmembrane domain, the xenyl peptide, and the extracellular region with 1, 1, and 8 leucine-rich repeats. The mutations are more than 100, so for many of them, they are private mutations in the single families, and all affect the coding region. They are missense on the right, or nonsense or frame shift on the left. Consistent with rare disease, 80% of patients were homozygous and 13 were compound heterozygous, with some founder effects in specific population. I just want to remind you that there are patients with the autosomic recessive Bernard-Soulier syndrome with alteration in GPIb-IX-V gene. We could have a combination of both Bernard-Soulier features and features of a syndrome associated with a macrodeletion chromosome 22q11.2, which is the region where the gene, the GP1BB, is localized. The feature of this syndrome, also known as velocardiofacial or DiGeorge syndrome, are congenital heart defect, palatal anomalies, developmental delay, and facial dysmorphism. So this combined feature derived from the presence of a microdeletion on one allele and a point mutation in GP1BB gene. However, since the microdeletion is not always associated with a clinical phenotype, macrothrombocytopenia and bleeding could be the only features of this patient. So as a genetist, we have to pay attention to this patient and evaluate carefully if there is any microdeletion and any hemizygosity in patient with alteration of GP1BB. Bernard-Soulier syndrome is classically a recessive disorder. So individuals with heterozygous mutation are expected to be asymptomatic, with a normal platelets count and function. However, there were individuals with heterozygous mutation in one of the 3 genes with either reduced platelet count, increase mean platelet volume, defect of the complex in terms of expression, reduced RIPA, or any combination of these. And in some of these patients, these abnormalities are severe enough to elicit bleeding diathesis. So a little bit of history of this form of disease, which appear to be autosomal dominant, and so due to only one mutation in one allele. The story started in 2001 when we had the possibility to analyze 2 large families with a clear autosomal dominant transmission of thrombocytopenia. Using a positional gene approach, we were able to identify a region on chromosome 17 containing a very strong candidate gene, which is GP1BA. And screening for mutation of this gene allowed us to identify this missense mutation alanine 172 valin, also known as Bolzano mutation, in all the patients in these two families. As now we know that this is the most common variant in monoallelic Bernard-Soulier form in Italy, in our country. 10 years later, we were able to enroll to study 100 patients with this specific mutation, the GPIb-IX-V gene, and here are the features. As you can see, the clinical and the morphological aspect of platelets are much less severe than in the biallelic form, as I showed you before. For instance, age diagnosis is 30 years, here again with a very wide range. Mild bleeding tendency, here the distribution of patients on the basis of the bleeding score. So as you see, the majority of patients do not bleed, and very few have a bleeding score of 3 or 4. Mild thrombocytopenia, mild macrocytosis with only large platelets, very rarely they are giant. What is very curious in terms of genetics is that all these patients share the same haplotype defined by this T at this position, the T which is the mutation, and 3 VNTR. So 3 of the repeats in the coding region of the alpha subunit. So that means that this mutation occurred as a single event many generations ago. We were able also to evaluate the expression level of the receptor on platelets membrane in 38 patients. As you can see here, for the expression of the alpha, of the 9, of the 5 protein, there is a significant reduction of 40% of the expression level of the GP1B9 and 5 complex. In vitro platelet aggregation is in the normal range for ADP, for collagen, even for IPA at higher doses, higher concentration. And when we use lower concentration, 1.5 milligram per milliliters, we found degrees of aggregation only in 5 cases. Since the first description of the Bolzano mutation, many monoallelic families with different mutations have been identified. And these mutations are not only affecting, they do not affect only the GP1B-A gene, but also the GP1B-B. And this is the paper that most contributed to associating the GP1B-B mutation with the monoallelic form of Bernard-Soulier syndrome. These authors analyzed 18 families. They identified 8 different variants: loss of the first methionine, missense, stop codon, in-frame deletion, frame shift mutation. What is a little bit interesting is that this mutation, tyrosine 113 cysteine, is the most frequent cause of monoallelic Bernard-Soulier syndrome in Japan. So there is another found effect in this population as in other populations, such as Denmark, for instance. They analyze the clinical, the platelets features of this patient, and they have the same phenotype as those reported in patients with the Bolzano mutation. And here are some parameters: mean platelet volume, this is the range, and mean platelet volume and this is the range. So large platelets, moderate thrombocytopenia, and usually not bleeding. Just to show you these two families with mutation in GPIb-IX-V gene. This is a mutation that is relatively frequent in Italy, and is I cannot see the title of the slide, sorry, I don't remember the name of the mutation. So this mutation affects residue 60. And as you can see here, we analyzed recently two families. And again, there is an overlapping with the phenotype we observed with the Bolzano mutation. Mild thrombocytopenia, mild platelet macrocytosis. We confirm, as in the Bolzano patients, the reduction of GP1B9 complex, and patients do not bleed, or they have a very mild bleeding tendency. And just to show you the platelets in these patients, so this is a normal control. These are the two blood smears from these three patients where you can see platelets larger than in normal control. These, in these slides, I will show you the mutation that are reported in literature, which are associated with the monoallelic Bernard-Soulier syndrome in both the GP1B alpha and GP1B beta genes. And as you can see in this square, some of these mutations have been also identified in patients with the biallelic Bernard-Soulier syndrome. And here, let me show you the effect of this mutation, this frame shift mutation, which is the only mutation identified in the GP1B beta gene, which was identified in two families, in which we have both homozygous and heterozygous individuals. So, as you can see from this table, here we have the platelet count done by automatic system, the microscopic count, NPV, the diameter, and the classification of the presence of giant platelets. So these three are the three children with homozygous mutation. As you can see, the number of platelets and the presence of giant platelets. So they have a macrothrombocytopenia as expected in the biallelic form of the disease, but they do not have bleeding. And in the heterozygous individuals, the parents, the sister, and even in these three individuals with the same mutation in the second family, we found that all of them have a mild macrocytosis, and these two and all these three individuals have also a mild thrombocytopenia, just supporting the role of at least some mutations that are associated with a phenotype in both heterozygous and homozygous patients, even if a different extent in terms of severity of the disease. This is a 23 base pair deletion determining a frame shift mutation. destroying completely the cytoplasmic domain of the GP1B beta subunit. As you can see, the protein is longer. The C-terminus of the protein, of the mutant protein, is longer than the wild type, as you see here. So we wanted to understand whether this mutant protein was stable, was expressed. Yes, is expressed. This is the Western blot, where you can see here the beta subunit in two controls, and the beta and the mutant subunit in the 3 affected children. And here the 2 parents with both wild type and mutant protein. By analyzing this Western blot, we could say that the protein, the mutant protein, is expressed, even if at a lower level, and probably the majority of the protein is degraded, but still expressed, at least in platelets. We wanted to determine whether the receptor was present, was expressed on surface of the platelets of this patient. And as you can see here, by flow cytometry of alpha subunit and I subunit, we found that the receptor is expressed of 30% of the control in the homozygous individual and 70% in heterozygous individual. So with so explaining the association with the different phenotype. And then we wanted to check whether the expression of these of the receptor on platelets membrane were associated or not with a defect in the platelets aggregation. And as you can see here, the aggregation is almost normal, even in homozygous individual using high concentration of ristosetting, is reduced using a lower concentration of ristosetting. So we think that this is, for instance, one of hypomorphic mutation of the GP1B subunit because of the expression of the receptor on membrane, because of platelets aggregation, and because there is not bleeding in the homozygous individuals. So it's clear that we have 2 different forms of Bernard-Soulier syndrome. The biallelic, which is autosomal recessive, is the most severe form. And you can recognize this patient because there is absent or strong reduction of aggregation induced by ristosetting. And how many frequent are these 2 forms, where the monoallelic is the autosomal dominant form? So this is a Pavia series of more than 300 consecutive Italian families with molecular diagnosis. And here you see the monoallelic, and here you see the biallelic, and they are among the more frequent inherited thrombocytopenia, at least in Italy, together with thrombocytopenia associated with mutation in myosin 9, in actinin 26, and in actinin 1. So what about the diagnostic approach? Thrombocytopenia in Bernard-Soulier syndrome is present since birth, since childhood. So it's very important to know whether there is any previous platelets count in order to discriminate between congenital thrombocytopenia and other forms, secondary or immunothrombocytopenia. Family history is also very important, at least for the monoallelic form, because it's autosomal dominant with almost complete penetrance, so that proband usually have one of the two parents affected and or other family members. The examination of blood smear is also very important to determine thrombocytopenia, to determine the platelet size, because, as you know, electronic counter do not estimate correctly platelet count and volume. The repass test is important to recognize the biallelic form of the disease, and also to differentiate in the differential diagnosis of this disease with other thrombocytopenia characterized by giant platelets, such as the thrombocytopenia associated with mutation in myosin 9. And again, also flow cytometry could be a useful tool in diagnostic setting. Obviously, mutational screening, which is very important for the monoallelic Bernard-Saultier syndrome, because no specific assay, at least at the present, recognize this form of the disease. Let me to conclude the spectrum of mutation and diseases associated with the defect of the GPIb-IX-V complex. This is platelet type von Willebrand disease, which is another very rare autosomal dominant disease with mild thrombocytopenia, mild moderate bleeding tendency. In this case, there is an increased agglutination, aggregation of platelets induced by ristosettin because of the presence of gain-of-function mutation of GP1BA, which enhance the affinity for von Willebrand. This mutation in bold in this position 246, 249, and 251 and 55 are all located in this terminal disulfide loop. This mutation have been known for a long time, and only recently the spectrum have been extended because mutation outside this loop have been identified. For example, this in-frame deletion in the affecting the macro glycopeptide, or these other two missense mutation affecting 2 of the 8 leucine-rich repeats. This disease is very similar to another disease, which is type 2B von Willebrand disease, which is associated a specific mutation of the von Willebrand factor. And so sometimes there are mixed diagnoses of patients with these two diseases. However, there is you can differentiate between the two von Willebrand disease, type 2B and platelet type, because you can use a RIPA test, RIPA mixing test. That means that you perform a RIPA test mixing platelets of patients with plasma of control and vice versa. Obviously, there is the sequencing analysis of both genes, the von Willebrand and the GP1BA genes. Let me to conclude with these slides say that the Bernard-Saultier syndrome in both biallelic and monoallelic form are very rare forms of inherited thrombocytopenia. They are characterized by variable expressivity. There are some difficulties in the diagnosis, leading to possible underestimation of both disease and or misdiagnosis. In presence, however, of giant platelets, we have to think of Bernard-Saultier syndrome, and the RIPA could recognize the biallelic form. Obviously, we can use genetic molecular testings, at least for the monoallelic form, but at least for our experience, a lot of diagnoses are inconclusive because of the presence of variant of unknown significance. Let me leave you with some open questions. So why thrombocytopenia when we have a defect in the GPIb-IX-V gene? We know that this complex, as I said, is closely associated with the cytoskeleton, which is involved in proplatelet formation and sustained platelet shape. So it may be reasonable to think that alteration of the receptor is also associated with defect in the cytoskeleton and then in platelets biogenesis. Another question is the effect of mutation in the monoallelic Bernard-Saultier syndrome. They act in terms of haploinsufficiency, or they have a dominant negative effect, at least for specific mutation, leading to abnormal glycoprotein subunity, impairing formation and function of the complex. And another point that I hope we could explain in the next year is the clinical heterogeneity, which is not typical of the disease, it's typical for many other, for many genetic disease. So it's possible that one explanation is the presence of hypomorphic mutation, as I show you in the last case I presented, or that the pathogenic variants maybe are associated with adverse or favorable polygenic score in terms of many other variants with a very small effect on platelets production and platelets function, which together could determine the more severe phenotype or prevent the most severe phenotype. So I let you with this open question because I do not have an answer for all of this one, and I thank you very much for your attention.
Thank you very much, Professor Savoia, for this great presentation. It seems like the audience has asked a few questions in the chat, in the discussion box. You can now stop sharing your screen if you wish, and then you'll be able to access the chat.
So the first question is from mean age of Bernard-Saultier diagnosis at 16. Yes, this is what we found collecting many years ago the 116 patients, and it's probably, I think, that it could be related to the fact that Bernard-Saultier syndrome, at least in the past, was presented as a severe bleeding disease. So in case of a patient with no bleeding or mild or moderate bleeding, maybe the suspicion of this disease was not taken into consideration. I'm sure that now a little thing change because because people involved in this field are aware of this possibility. Hello, could you tell us the frequency of only platelet symptomatology? I cannot see anymore the question. Sorry. Okay.
Are you able to find the...
Okay. Could you tell us the frequency of only platelet symptomatology of deletion of microdeletion on chromosome 22? So I cannot say you the frequency because there are a few cases reported with both microdeletion and point mutation on the other allele without any symptomatology of the microdeletion syndrome. We also had the possibility to analyze one case in our family, and the patient had a paternal mutation and de novo microdeletion, and no sign of the microdeletion syndrome have been revealed in this patient. Feel free to use, okay, sorry. Does the expression the complete that the expression of the complete still absent at the surface of platelet, or can see sometimes a residual expression? So I think that, there are patients with a residual expression, and I think that the case I show you with the frame shift mutation in GP1BB gene is the case. There is not a residual expression. The expression is 30% of control, and I don't know if it is a reason, but patients do not bleed. But I know the number of patients is very low to make any plausible correlation between genotype and phenotype. So we have biallelic cases with residual levels of GPIb-IX subunit, and yes, I mean, I think it would be nice to see whether this mutation, I mean, I don't know if this mutation is new. If it is not new, maybe check if there are data in literature showing a residual level, or maybe it's a new mutation. It could be classified maybe as a hypomorphic mutation. Thanks. At least 3 independent pedigrees, if I remember correctly, may be related to the microdeletion. I don't know the answer in the chat. So what to do if a genetic reveals a novel heterozygous variant in the BBS genes? So I think that we have the group of Trieste have, let me say, at least 30 different novel heterozygous mutation in patients with a moderate thrombocytopenia, and we do not know what to do because this variant have been classified as a variant of uncertain significance, and I think that it could be very nice if we could set up in vitro assay in terms of overexpression of the mutant protein and see whether or not we can reproduce the complex on membrane, and if the complex is present, to see whether or not there is any binding any response to the von Willebrand factor. Do you use the ratio of the 3B, 3I, 1B to evoke? No, I don't know. I cannot answer to this question because I do not perform flow cytometry by myself. Usually our flow cytometry analysis has been done in Pavia by Alessandro Pecci. And so I'm sorry, I'm not able to answer to this question. Just for the general information, clinging group of variant curators for platelet disease were now curating, just for the general information, in the gene clean group of variant curators for platelet disease were now curating variants. I don't know how to answer to Jose Rivera question. What about our ESO antibodies in Bernard-Soulier syndrome? I don't know. I don't know again to answer this question. And I don't remember if in the collection of data we have done a lot of years ago, we had this information. Mathieu, even I cannot answer to this question again. So I'm sorry, I'm not able to answer to some question, and I'm sorry for that.
Thank you very much, Professor Savoia. You still have 1 or 2 minutes if you wish to add any other questions in the chat or in the Q&A button. Yeah, we can see the audience and the coordinators thanking you as well, Professor Savoia, for your presentation. We can wait for 1 minute if anyone else has any other questions. Okay, thank you very much again, Professor Savoia, for your time and expertise.
Very much for the invitation.
And thank you to everyone who has attended this session. You can join us on the next webinar of the topic on focus on constitutional thrombocytopenia. This session will be on MYH9 related disease and will be led by Professor Lozano and Dr. Rivera. It's going to be next Wednesday, the 7th of February. Sorry. Thank you again, Professor Savoia. Thank you, everyone, and I wish you a very pleasant evening. Thank you again.
Thank you. Bye.